I want to thank everybody for coming out today. My discussion today is going to be on diabetes medication. We're going to talk about oral medication, and we're going to talk a little bit about injectable medications. So I want to say that the way our industry, the pharmaceutical industry, labels a medication is by one of two things. It's either by a mechanism of action, in other words, how a drug works in the body, what it does, or by its chemical makeup, okay? So it's basically one of those two things. And that's pretty much across the board, does not only apply to diabetes medications, okay? So my presentation today, I'm going to talk a little bit about oral agents, and these are basically the oral agents we have on the market today available, okay? We have biguanides, and I'll discuss each of these in a little detail further on. We have sulfonylureas, and this is the SU is kind of, our abbreviation for sulfonylureas. We have meglitidine derivatives. We have alpha-glucosidase inhibitors, Thiazolidinediones, dipeptidyl peptidase 4 inhibitors, and selective sodium glucose transporter inhibitors. First of all, let's say in general about all the previous classes of drugs that I just talked about, they all have their inherent side effects, and it's kind of a do's and don'ts to each particular class of drugs, and even within one class of drugs, there are drugs that maybe differ a little bit from one another, which gives it the uniqueness. I'm not really going to talk about those differences today, because it would just, I would be here for 3 days if we went ahead and did that. So let's talk about guanides, okay? And usually, guanide is something, I'm going to start kind of from the bottom. So usually, what biguanide do we know? Well, everybody kind of knows metformin, okay? So let's just say biguanide is metformin. And this is really the first agent that we're using today to treat, to treat diabetes. As Janet said, the first thing we really try to do as a physician is to try to get somebody to go on that exercise plan, or go on a proper meal plan. And do those things work? Yes, they absolutely work. Do they fail? Yes, they do fail. Why do they fail? Basically because people don't do the 150 minutes a week of exercise, or just don't eat properly. So a physician says, listen, we tried, didn't quite work out for you, so we're going to put you on metformin and biguanide. Usually first oral agent for type 2, okay? And I want to talk a little bit about mechanisms of action, okay? And in the biguanides, what they do is they decrease hepatic gluconeogenesis. In other words, they stop that outpour of sugar from your liver, okay? And they increase insulin sensitivity in the periphery, okay, in muscle and fat. Remember Janet talked about how what the basic definition of diabetes was? Well, this fits right into that definition, okay? What do we have to worry about with metformin? Well, we have to worry about a patient who has renal problems. Either they're starting to go into that, they've been diabetic, but they're starting to have, remember she said about the neuropathies and the microvascular issues with the kidneys, the eyes, and all those things. Well, we have to be very careful about what a patient's renal function is when we put somebody on metformin, because it's cleared through the kidneys. So we have to make sure that they have good renal function before we put them on metformin. And what happens is if metformin builds up, okay, if your kidney is not getting rid of that extra, that metformin, or it's derivatives, it can lead to lactic acidosis. Lactic acidosis is just a problem with your body that, you're going to be hospitalized for lactic acidosis. Your body doesn't have the normal acid-base balance that it has, and it could be a problem. Okay, so next is the sulfonylureas, okay? And these products have been around for a very long time. They're probably, one of the first treatments that there was for diabetes. If you can think somebody who had maybe a mom or a grandmother or something who was started on an oral agent for diabetes, they were probably started on, one of these items. And again, I'm going to start from the bottom to give you examples of what we have. We have basically 3 drugs. We have Glyburide, Glipizide, and Glimepiride. The way they work is they're what we call secretagogues, okay? And that means that they stimulate the release of insulin from those beta cells, in the pancreas. So they kind of say when your sugar starts to go up, you take your medicine. You're going to start to just pump out this insulin. That's how these SUs work. They decrease hemoglobin A by C by about 1 to 2%. So that's a good drop in A1C. Okay, and they decrease blood sugars by about 20%. Okay, and what is it that we know about some of these drugs? Well, I'm going to say it now. I'm probably going to say it a couple of times during my presentation. Is that metformin is like a standard, okay, that's combined with a lot of these drugs. Like you have 2 medicines in 1 pill. So you're kind of getting a 2 for 1. Okay, so you're getting a real good buy with some of these. So Glyburide is available with metformin in 1 pill, a bunch of doses, different doses. Glipizide, the same way, available together with metformin. Glimepiride was, I don't know if it still is. It's just, I haven't seen it in a while, so I don't even know if it is, but it was once upon a time available with metformin. Glyburide has a pretty big propensity for hypoglycemia. Glipizide in the class is probably the best as far as not as much hypoglycemia. So those are things, like I said, that we have to really consider in some of our patients, how high their blood sugars are, how well they're going to be able to control themselves, and again, knowledge of their own disease state, how to manage their numbers. Yes.
I just want to jump in for a second too, because I know it's a lot of information related to the drugs. As diabetes resource coaches, even if you do have if you were in healthcare or whatnot, we don't want you to feel like you have to know every last bit of information about these drugs and what they do and how they, would affect the person that you're speaking with on the phone. We leave that to their pharmacist and to their doctor and to their own personal dietitian. What you guys will do as the coaches is understand this, start to hear it. When you talk to somebody who has type 2 and they're taking glipizide or they're taking glyburide and they say, oh, I'm not feeling great, that's just going to trigger you to say, well, it sounds like this might be an issue that you need to discuss with your pharmacist. Who's your pharmacist? Do you need that pharmacist's phone number? Or have you spoken to your doctor in 3 months? Okay, I'm going to motivate you to give him a call tonight because something's not right. So you're sort of that middle person. But I don't want anybody to feel like they have to memorize or know every single thing that Ralph is saying, or even when the dietitian speaks later from what you've heard from Janet earlier. It's just for you to really be that facilitator. You're that middle person getting them to where they need to be. These guys are the experts, and we want those patients that we speak to go back to their own personal expert. If they don't have an expert, if they say, I don't know a pharmacist, Ralph at Liz is happy to talk to them. Or if they live in South Jersey, we were going to find that local pharmacist for them in South Jersey that they need to speak to, or that dietitian. But we don't want to feel like we're giving out that information to them, nor should we. And we don't want you guys to have to feel like, oh my gosh, I have to know all this in order to be a good coach. Absolutely not the case. So I just want to make sure you guys know that, because I know it's a lot.
Yeah, there's a fine line as to what you can really tell somebody about medication. If you're not a licensed professional in the state of New Jersey, you're probably just looking at, 1 or bad news, God forbid something happens.
That's exactly what we
Yeah, so you want to steer away from that, and I think,
We want
the
to-
best, the best, we could do for somebody, and I say we, I'm talking about coaches, I'm not talking about myself as a pharmacist, I'm talking about the coaching is, like Bonnie said, refer them to the professional who can legally answer their question, whether it's Janet, whether it's Ralph, whether it's everybody. And I want to say something about pharmacists is that, we are, of all the health professionals, okay, we are probably the most accessible health professional there is. And just think about this for 1 minute. Just think about this for 1 minute, okay? I don't know how many drugstores there are up and down Route 4 or up and down one of these streets, okay? But if you walk in there, you don't feel good, you have a cold, you have diarrhea, whatever, okay? You walk into that pharmacy and ask to speak to that pharmacist, okay? He's not going to ask you to make an appointment. No. He's going to say to you, give me a minute, let me finish what I'm doing, and I'll be right with you. So you're very, very accessible to a pharmacist, okay? If you call your doctor, Doc, I want to speak to the doctor. They'll put you on hold for 20 minutes because he's taking care of somebody. They may say, I'll call you back at the end of the day. You know what? At the end of the day, you probably had 20 bouts of diarrhea. You're about to, pass out. So, pharmacists, we are the most accessible, healthcare provider out there. So you could always revert, if it's a question regarding medication, please have them call their pharmacist. Everybody has a pharmacist. Everybody's close enough to a pharmacist. They have to go to the drugstore somewhere, along the line. If they're being treated for a chronic condition, they have to get their refills every month. So they have to have some kind of a interaction with their pharmacist. Okay, let's move on to the Alpha-Glucosidase Inhibitors. We refer to these as AGI. And we basically have two of them. And in my practice, I don't really see a lot of AGIs being prescribed. And I think that's pretty much kind of a standard in our industries. They kind of fall into the wayside, okay? And how do these work? Well, they prolong the absorption of carbohydrates in the gut, preventing postprandial glucose surges. So,
Ralph, please define gut. What is the gut?
Your digestive tract.
Okay.
Stomach, intestines, okay? Stomach, intestines. And postprandial, this is after eating, your glucose that goes after eating. The way these drugs are taken is usually at first bite of a meal, okay? So they work for a very short period of time. They work quick and that's it. So you're going to take it if you're going to eat. If you're not going to eat, you're not going to take your medicine. What limits their use is they cause flatulence, okay? That's uncomfortable. This is a big problem, metformin too, flatulence. So, and any kind of GI side effects, metformin has, is a problem with that, okay? And their effect on their glycemic control is modest. So if they're not really, great drug, not a terrible drug. Are they used? Every now and then, but not a whole lot. Move on to the next one, please. Okay, let's talk about TZDs, Thiazolidinediones. We have in this market are pioglitazone and rosiglitazone. Okay, and these drugs decrease insulin resistance in muscle and fat. Remember, Janet's talk about insulin resistance, muscle and fat. Well, here we go. This is one of the mechanisms by how some of these drugs work. And it's proven that they preserve beta cell function. So remember we talked about where is insulin produced? It's produced in the pancreas, specifically in the beta cells. So these drugs preserve that beta cell function, okay? They have a moderate effect on glycemic control, and from what we understand, it's somewhere between, that 1-2% drop in the sulfonylureas and a modest effect of the AGIs, okay? The two drugs that we have is Actos and Rosiglitazone. Actos is pretty much easily available just about anywhere. Avandia, which is Rosiglitazone, I don't know if anybody remembers, it was about 7 years ago, there was a lot of talk about the cardiac problems with Avandia. Well, now Avandia it could still be obtained, but it has to go through specialty pharmacies and things of that nature. Are doctors still using it? I'm sure there are. But, should they be using it? I don't know. I believe that an oral agent has to go through a lot to be absorbed in the body for it to work. So you have to take the pill. It's got to get to your gut. It's got to be broken down. Your body has to absorb it, then it's going to do its job. So in that whole process, a lot of things are going on. How effective is it? It's a good question, Jack. I'm not quite sure, exactly what it's doing. Is it an aid or an adjunct in decreasing that resistance? Yeah, but again, it's an adjunct with other, with other agents. And again, pioglitazone and rosiglitazone, they too are combined with metformin in one pill. Remember that 2 for 1 is like buy one get one. Well, that's what we have, with these two drugs also. Not very common. They're still available. Still out there. You can go to the next slide, please. Okay, DPP4 inhibitors. These are a newer class of agents that we're using to treat diabetes. And the drugs that we have in this class are allogliptin, which is brand name Nesina, linagliptin, brand name Tradjenta, saxagliptin, brand name Onglyza, and sitagliptin, brand name Januvia. These drugs also, buy one, get one, with metformin. They're paired with metformin, in the same tablet. They come with metformin, a whole variation of doses and stuff like that, okay? Expensive, very, very expensive. Okay, we're talking 30 days of any of these. Okay, it could be about $400 to $500 for 30 days, 1 pill a day. Or in the case of Januvia, Janumet, you may take it twice a day. Still 30 days would be $400 or $500. So they're very, very expensive. Yeah. In practice, I get prescriptions, and I have to stay in business. And if you go to a doctor and a doctor prescribes something for you, and your insurance doesn't cover it for whatever reason, okay, it's my job to say, hey, this is a therapeutic equivalent that we can provide to the patient, okay, for you to go on. So I don't just call a doctor and say, hey, it's not covered. I try something. I make sure I get a paid claim. Once I get something that's paid, then I will move on and call the doctor and almost suggest. And then if he says it's okay, we have to make sure that it's still the right drug, the right therapeutic interchange for that patient. Okay? So what do the DPP4 inhibitors do? They increase insulin release, and they decrease glucagon levels. We didn't talk about glucagon much, but glucagon is kind of like the opposite of insulin. So if you know what insulin does, glucagon will do the opposite. Okay, so if we can just remember that. And what they do is it degrades GLP-1 and GIP, and this all happens, in the gut. It's in a glucose dependent fashion in the gut. And when we talk about the products like Victoza, we're going to see that this plays a role in all of that. Okay, we can move on to the next. Did you have a question? Did you want to say something? Yeah. Okay. And this is the newest class of oral agents that we have to treat diabetes. These are the Sglt2 inhibitors. Okay, and they are somewhat used. Okay. Some warnings that we have to worry about. There's some, a lot of times it can't be used, patients with renal problems, okay? And basically, how these work is by lowering the renal glucose of the renal glucose threshold. Okay, that means how much sugar is going to be reabsorbed by your kidney. So it kind of pushes sugar out through your urine. Okay. With that being said, we come to this and this is the reason why they cause those mycotic infections, very common in females. So even diabetics per se, a lot of women develop vaginal infections due to that sugar constantly coming out in their urine. Well, the Sglt2 is kind of more of a culprit in doing that. So, if you speak to a female, if you're as a coach speak to a female, you're feeling okay, well, you know what, I have problems, I have a UTI or something, maybe it could be due to one of the drugs or something, maybe it's, something going on with that. So, I don't want you to diagnose or do anything like that, but just know that it could possibly be that. Say, hey, maybe review the drugs with your doctor, and see what's up. Again, these drugs are also combined with metformin, so you get that, kind of buy one get one. And they're taking usually once a day. A lot of them are taking, if it's with metformin, they're usually taking twice a day. And I don't know if you've seen, sometimes you're sitting there watching TV, all of a sudden, hey, did you take Invokana or this or that? Have you had a lower limb amputation due to Invokana or one of those drugs? Well, yes, there's a warning in the package insert about lower limb amputations in all of the drugs. So it's not like doctors don't know that the studies shown that it's there. It's there.
They just came out with a new trial with Invokana that's actually not true anymore.
It's not. It's
Canvas trial.
yeah.
They came out with saying it was a false positive in the previous trials.
Wow.
Really.
And this trial was like 15 years long in the UK, and so it was a great trial. They were trying to do the cardiovascular outcome trial, so
Okay.
they studied that too, and it turns out to be that was actually a false positive.
That was a false positive. That's good news. Well, one thing about the pharmaceutical industry is that, and I guess medicine too, is we're always doing trials on drugs. We're always researching, what's going on. And just because a drug comes to market doesn't mean everything stops. No, there is still research going on as to things that are happening. I think more so in Europe than the United States. Usually something happens in Europe, then we find about it here. So, those are, it's good to know.
Yeah, I think that one is Jardiance. And
You may be right. Yeah, I think you may be right. Can we go on to the next one, please? Okay, so let's talk about the injectable agents a little bit. And basically, I'm only going to talk about these two. I'm not going to talk about these. These almost they're not even used as far as I've dispensed this once in my life, one of them, and I didn't even really know what I was doing, but the doctor gave it. I said, okay, you're familiar with the drug, go ahead, go, and that was it. So I hate to say it as a pharmacist, that's not what you want to hear from me, but the doctor said, just order it for my patient, I don't want them to have it. So they never came back for a refill. I dispensed it once, and that was it. Never saw a patient again. So basically we're going to talk about insulin and the glucagon-like peptide 1 receptor agonist, okay? So the insulins, basically the way we are categorizing insulin is by how fast they start to work or how long they work, okay? And what we have is let's talk about the rapid-acting insulin. Their onset is 5 to 15 minutes after being injected, okay? And their peak, that peak means, when they have their most effect And then the duration is how long they work for, okay? So these fast-acting insulins are insulins that a person with diabetes is going to use just before their meal. So they're going to sit down to have their breakfast, lunch, or dinner, and they're going to inject the number of units, either sitting down or during their meal, but for the most part we say just before your meal. Okay, you sit down, you have your meal, and then the insulin will start to work. It'll peak, like I said, about 30 to 90 minutes, and it'll only last for about 3 to 5 hours. Okay, can you put a stop clock on these things? No. Every patient's individual, depends on how much you eat, your body weight, a bunch of things. But for the most part, that's true. And what are these rapid-acting insulins? Well, these are kind of like their generic names, but let's kind of say anything with a log is a fast-acting insulin, okay? And then we have Thiaz, which is Aspart, we have Apidra, we have Novolog, we have Humalog, and we also have the inhaled insulin, Afrezza. Again, my practice, don't use it too much, and I'm not even sure it's used that much throughout the country, because I've looked it up a few times to see how many my wholesaler have in stock, and sometimes they have 6 pieces left. And that just kind of tells you that they're not really.
I think the manufacturers have largely dropped it.
I'm sorry?
They've dropped it because people aren't interested in it.
There was things with if you had COPD or if you had problems swallowing, you really couldn't take it. So there was kind of mechanical issues with it. And just that whole cartridge system with adding up all these different cartridges, putting in that device. I mean, the delivery of the drug just was not attractive. So I think that has something to do with its not becoming a good thing. And 2, needle technology has changed so much. I mean, I've had to, I've taken a lot of diabetes courses, and they always show us to inject ourselves. And the needles, I mean, you can't even feel some of these needles. If you put your finger, where you want to inject, this hurts more than the actual needle prick.
Janet said they've come a long way.
They've come a long way. They have
They used
come
to
a
be
long
much bigger, and you're right, they're just, it's
Yeah,
wonderful.
they're tiny, they're thin.
Yeah,
Yeah, they have
wonderful.
the way the points are and
Yeah.
everything. It's great. It's awesome. It's awesome. Okay, we can move on to the next one, please. Okay, and they have a slower onset. In other words, they'll begin to work a little slower than the log insulins. Okay, their peak is about 2 to 4 hours, as opposed to the other ones of about half hour to an hour and a half. Okay, and they last for 4 to 6 hours. So as you can see, is the differences in insulin. There's like a little bit difference in their onset, their peak, and their duration. Slight differences, but differences nevertheless. And what we have in this class is the regular insulin, Humulin R, Novolin R, and Relion, which is that Walmart brand. They have their part 2, which is a Novo product. And then we also find that there's a commercially available product that has the regular insulin mixed with NPH, okay, which is a short-acting and a longer-acting together, okay? And these products are Novolin 7030 and Humulin 7030, and I'll talk about these a little further down. Okay, we can move on to the next one, please. We have the intermediate acting insulins, and their onset is about 3 to 4 hours. Okay? The peak is 8 to 14, and again, this is, you say, wow, that's a big change. It's a big change, but that's the way these insulins were engineered, so, we can make them last longer. I'm sorry.
No, I'm
Jenny,
sorry.
you're good? Okay, and their duration is about 16 to 24 hours. And what we do is we combine these with faster acting insulins to maximize the effects of a single dose. So remember before I said the Humulin R was combined 70-30 with a longer acting insulin? Well, here's what it was combined with. And the reason for that was so people wouldn't have to inject themselves as often. So they would have this insulin throughout the course of the day. Okay? Still used today. You know, I mean, there are situations, you know, like we have 2 exceptions to the rule in the room right here. Okay, but, you know, a lot of people on the go, hey, they want to do their 22 units in the morning, you know, off to work they go, and they watch, you know, their carb intake and things like that. So it does work for certain people. And what we have to say about this is that when you pick up a vial or a pen of any of these intermediate acting insulins, you're going to see that they're cloudy. Okay, that's the nature of that particular product. And what we have to do is we have to take that insulin and roll it in our hands to make sure that the particles are suspended. Okay, otherwise it's not going to work out for you.
Excuse me.
Yes.
And there's a very tricky insulin. I used to be on it, and that peak really can lower someone's blood sugar, and you could really crash. So again, you know, with these kinds of insulins, the long-acting, it's so important to carry these glucose tablets and things to, in case you can't eat at a certain time.
At a certain.
Because for me, I remember it triggers at a certain time, and it's wonderful, but yet it can be a bit scary. So it's really important to carry those snacks through the.
Definitely.
That's
Definitely.
a pretty wide peak, 8 to 14.
It is, but that's what research shows. So that's what I put in there. They, you know, insulin is your biggest culprit of hypoglycemia. Okay, a great drug does the job, but as Jack said earlier on, you know, it's bad to be high, but it's worse to be low. And unfortunately, insulin is just one of those things, kind of like a double-edged sword,
Right.
that can make you go low, and that's a lot of problems can happen at the low points. Okay, so we want to roll it in our hands to mix them, and you know, for the most part, these types of insulin, except for the log and a long-acting insulin, all the other insulin is pretty much used in type 2s. Okay, the rapid-acting and the long-acting insulins are usually used in type 1s. Okay, because you want to make sure that they get that little bit of insulin they need when they need it, and a lot of them are controlled on a basal insulin, which is going to be the next class I'm going to talk about, which has a long effect during the course of the day, sometimes 36 hours, sometimes even up to 42 hours. Okay, so that brings me to the long-acting insulins. Okay, and these insulins have very slow systemic absorption. So, you know, if your blood sugar is high now, you're not going to inject your Lantus. You're not going to inject your Toujeo because it's really not going to do it for you. Okay, these insulins start to work slow, and then they have a nice steady flow during the course of the day, or maybe day and a half, or even sometimes almost 2 days, where they start, you know, coming down again. Okay. Like I said, duration varies from 24 to 42 hours. And what we have in this class is glargine, which is Lantus, Toujeo, and Basaglar. Okay, and we also have another one called Degludec, which is Tresiba, and it's found that this works for about 42 hours. Does that mean you're going to only inject it every 42 hours? No, it does not mean that at all. You have to use it every day. Okay. These drug companies are getting very inventive with the products that they want to use. So they said, hey, we're going to take long-acting insulins, okay, and pair them with these GLP-1s and come up with new products, okay? And they're using it and it's working, okay? So that brings me to the GLP-1 receptor agonists, okay? What do these do? They mimic the GLP-1. They stimulate glucose-dependent insulin release, and they reduce glucagon secretion and slow gastric emptying, okay? So this is something that's very favorable, okay? Gastric emptying, it's also something that can be a little bit of a problem, okay? So they seem to work very well in glycemic control and weight reduction. Why weight reduction? Because of that slow gastric emptying, okay? The products we have here are exenatide, that's Byetta and Bydureon, liraglutide, Victoza Saxenda, dulaglutide, Trulicity, lixisenatide, Adlixin, and semaglutide, Ozempic, okay? And let's get back to this slow gastric emptying and weight reduction. So when this product came out on the market, Victoza, okay, it was found that it was getting those A1Cs down, okay? They also found that a lot of these diabetic patients were losing weight, okay? So the manufacturer said, gee, we have a great product. It's going to do two things. What do we want all our diabetics to do? Lose weight, right? And we're controlling their A1C, awesome. So the FDA said, listen, Victoza, we're not really going to approve it for weight loss. Okay, we can just go with the glycemic control of the product. They said, fine. They came out with a product, Saxenda, which is exactly the same product, and that product is marketed for weight loss. Okay, and like I said before, what they've done is they've taken liraglutide and lixisenatide and coupled it with long-acting insulins to make one product. Again, it's like kind of a 2-for-1 thing, you know, a 2-for-1 situation like metformin with all the other classes of drugs. However, those products are not for everybody. They have to be within a certain range of their long-acting insulin for this to be effective. And the problem with the GLP-1 receptor agonist is that the GI side effects are the side effects that limit how we can proceed with the dosing of these products. So a lot of people have a lot of cramping, even vomiting from these products. So it's to a point that they either have to back down on the dose and in some cases even discontinue the drug altogether. So the side effects are kind of the rate limiting step as to how we're going to proceed with the GLP-1. Okay? I have people come to me, you know, the doctor started on a new medication and they want to know all the side effects, and I tell, here, read the package insert, okay? And unless you're a doctor, you figure out whether or not you want to take this drug, okay? Side effects, why are they in those package inserts? Because they were reported. They were reported, so the FDA requires that all this be printed in that package insert. Does it mean it's going to happen to you? It doesn't mean that at all. Can it happen to you? It may. You may be that 0.01% of the population that gets that particular side effect, okay? There are things that are happen in higher percentages, like the GI side effects from these drugs. Yeah, can we expect that? We absolutely can. Is it to a point that, like Jack said, it was something that necessitated discontinuing the drug? Well, yeah. If you're going to take a drug, it's going to make you feel miserable. You don't want to stay on that drug face and come on. I wouldn't either. You know, I wouldn't either. And the right advice was go on. You know, speak to your doctor about it. See what he has to say. Okay. And I think that's it. Pretty much it.